Good evening, everyone, and welcome to tonight's webinar. This is going to be 167th Fireside Chat and the fifth session, I think, on the webinar series for onconephrology. And we are going to have a very interesting topic today. Basically, we're going to cover monoclonal gammopathy of renal significance and looking at case-based insights. So looking forward to a very interesting session. So my name is Dr. Yuri, and I'll be the moderator for today's session. And we are joined by a very distinguished Associate Professor, Dr. Sabine Karam, who's going to take us through the topic for this evening. And just a little bit about her, she did obtain her medical degree from the University of St. Joseph in Beirut, Lebanon, and an internal medicine residency at Albert Einstein College of Medicine in New York. And she did her nephrology fellowship at the George Washington University Hospital in Washington, D.C. She completed an international master's in organ donation and transplantation at the University of Barcelona, Spain, and the 2021 Emerging Leaders Program of the International Society of Nephrology. She is AIBM certified in internal medicine and nephrology and certified since 2013 in hypertension by the American Society of Hypertension that has since merged with the American Heart Association. She is currently an associate professor of medicine in the Division of Nephrology and Hypertension at the University of Minnesota and an adjunct faculty at the American University of Beirut, Lebanon. She was previously up to January 2022, the director of the Division of Nephrology and Hypertension at St. George Hospital University Medical Center in Beirut, Lebanon, and an assistant professor of clinical medicine at the Faculty of Medicine and Medical Sciences of the University of Balamand in Lebanon. She's passionate about serving the scientific community, and in that regard, she serves on several committees of the International Society of Nephrology, where she currently is the chair of the Young Nephrologists Committee, the American Society of Onconephrology, the National Kidney Foundation in the US, and the French-speaking Society of Nephrology. Her clinical and research interests include onconephrology, hypertension, and peritoneal dialysis. So looking forward to a very enlightening topic today. I'll give it over to Dr. Karam to take over the session.
Hello, good afternoon or good night, because I know that you're several hours ahead of me. Thank you for the kind invitation and for the honor to speak to hopefully new friends and old friends, because I see a couple of names that I know already on this call. So today, it's not going to be easy to do it in a limited time, but I'm going to try to discuss with you the right approach to monoclonal gammopathy of renal significance. I have no disclosures. We're going to together define what is a monoclonal gammopathy and how do we screen for it. We're going to outline the evaluation of patients with a monoclonal protein and kidney dysfunction. We're going to try to put together the specific characteristics of the different monoclonal gammopathy-related kidney disease. And then if I have time, I'll just say a few words about the current principles of management. So I'll start with a case. So we have a 77-year-old retired nurse administrator who was first seen in clinic in August 2022 for CKD management. Her past medical history was significant for breast cancer. She had had a bilateral mastectomy, radiation, and chemotherapy. She had hypertension for more than 10 years and type 2 diabetes for more than 10 years, anemia, and CKD. For her hypertension, she was on hydrochlorothiazide, 12.5 milligram daily, and lisinopril 20 milligram daily. And she reported that lately her blood pressure had been running low. From a renal standpoint, her creatinine level had been stable for the prior 2 years and around 1.1, 1.3. And at the time of the visit was 1.2. UACR was at 554 milligram per gram, while it was around 75 in 2018, so 4 years prior. Despite the fact that, again, she was on HCTZ and lisinopril. The rest of her labs were noticeable for mild hyponatremia and a sodium level at 133. So I subsequently stopped the hydrochlorothiazide, but because her blood pressure started rising, I increased the lisinopril to 40. She reported a new onset diarrhea after a few months duration and reported having intentionally lost a few pounds. Her physical exam was not really significant for anything. So her lab values, so if we look together, we notice that her white blood cell count was borderline low since 2018, 2019. And she had worsening anemia in 2022. And I certainly got concerned about a new or a recurrent malignancy given her history of breast cancer. Her HbA1c had seemed to have always been controlled. And while her creatinine levels seemed to be kind of stable over the past couple of years, there was certainly a difference between 2022 and 2018, 2019. She also had significant proteinuria, which was not present before. And for that reason, and because her diabetes was controlled, and because I didn't know how long the proteinuria had been there, I screened her for monoclonal gammopathy. And this is what I found. I found a disproportionately elevated kappa chain as compared to the kidney dysfunction with a ratio of 5.18 and a monoclonal gammopathy on the serum protein immunofixation at 2.9 gram per deciliter. So we'll start by defining what is a monoclonal gammopathy. So a monoclonal gammopathy, the strict definition, is the presence of a monoclonal immunoglobulin in the serum or the urine or both in its intact form or as fragments. So remember, it can be a complete immunoglobulin or it can be a fragment of immunoglobulin. And it can be produced by an expanded clone of either B cells, plasma cells, or lymphoplasmacytic cells. All those basically being B cells, but at different stages of maturation. And if we're dealing with plasma cells, in general, the most common one would be IgG, while if we're dealing with B cells and lymphoplasmacytic cells, the most common would be IgM. And that's important because the treatment would be slightly different. What is epidemiology and prevalence of monoclonal gammopathy? So the most known epidemiologic study, but there has been others been done, but probably the most comprehensive so far, comes from the Mayo Clinic. So this is why it says Olmsted County, Minnesota. And this landmark study, which really is remarkable, found that asymptomatic monoclonal gammopathy was found in more than 3% of the population more than 50 years of age, and more than 5% of the population of more than 70 years of age. But if you use a new technique that's only present so far in few select centers in the world, and upon which I'll touch base very briefly, and taking the same population, you'll find that actually the prevalence is much higher, and it's more than 5% of the population more than 50 years, and more than 7% if it's more than 70 years. Interestingly, since I'm talking to an audience from Africa, the prevalence is twofold higher in Blacks compared to whites. And there are other epidemiologic studies, and there is a study coming from Ghana where they did SPEP with immunofixation, and they found that the prevalence was 5.8% in males, so the study was done only in males aged more than 50 years old. And so I presume that this is probably more prevalent in your continent than in the rest of the world. It can regress in 2 to 5% of the cases. Now, how do you usually screen for it? So I already mentioned that for this patient, I did an SPEP with immunofixation, and I did a serum free light chain assay. So how frequently do you use the serum free light chain assay in Africa? Can someone tell me?
We can do the tests. The testing is available. It takes a little time, maybe sometimes a week or more. And when you suspect an elderly person with unknown etiology of renal failure, and you suspect there could be monoclonal gammopathy, then we ask for the test. Yeah. It may not be done in the same, may not be done in Tanzania. It is sent probably to South Africa sometimes. Yeah, there are some labs that do it now, but quite often it may not be done in the same country sometimes. Kenya, yes, it's done. Tanzania, sometimes yes and no, depending on the labs. And Rwanda definitely, I think, is sent out. Or it's probably Lancet. Dr. Nando will know. Thank you.
Okay, so that is an important point because the serum free light chain assay, as the name says it, will screen for light chains, right? So if you're dealing with a monoclonal gammopathy of a fragment, then it wouldn't be picked by SPEP with immunofixation. So that if you just do SPEP, it has a low sensitivity for the detection of low levels and especially free light chains. So going from an SPEP to the serum free light chains, it's a matter of sensitivity overall of the test and immunofixation, but it's also about what does the test is able to detect. And so to be complete, ideally, in every patient that you're trying to screen for monoclonal gammopathy, they should get an SPEP with immunofixation and a serum free light chain assay. And also in general, hematologists use a serum free light chain assay to monitor response to therapy. In general, the general teaching is that there is a renal ratio for serum free light chain assay, meaning if you have CKD, and this was brought about by the International Kidney and Monoclonal Gammopathy group, that if you have CKD, you have a renal ratio which goes between 0.2 and 3.2. So anything outside of that ratio is considered abnormal. And that's because both kappa and lambda have renal elimination. However, there is an ongoing impressive study going on in Iceland. Iceland is a small country where people are genetically similar, and they have a population-based registry. And obviously, it makes sense, but what they found is that you have a new reference, they found new reference intervals according to the level of GFR, because obviously the chains don't get eliminated the same way according to the level of kidney dysfunction. And this is to show you, basically, if you just do an SPEP with immunofixation, and we're talking here about hematologic disorders, like multiple myeloma and AL amyloidosis, for which there is no question that they should be treated. You obviously miss a lot of cases if you only do an SPEP with a serum immunofixation. And basically, if you do an SPEP, a serum immunofixation, and a serum free light chain assay, you detect virtually all the cases in myeloma, and you only miss around 3% of the cases for AL amyloidosis. Knowing that, obviously, and you all know this, that AL amyloidosis is part of the MGRS, is considered part of the MGRS, and is by far the most common one. And the difference between AL amyloidosis and the rest of the MGRS is that the treatment for AL amyloidosis is very well codified. There is no controversy about whether the patient should be treated or not, while there is still a lot of controversy about the right treatment and how aggressively other types of MGRS should be treated. And in general, people have started more and more separating AL amyloidosis from the rest of the MGRS, where there is more of a gap in terms of knowledge and understanding. To continue with our case, the next step was to send her to see a hematologist. She had a bone marrow biopsy, and it actually was consistent with there was a plasma clone on this biopsy, and the percentage was 20 to 25%. So just and we'll get in a second to what this means. She also got imaging, and a skeletal bone survey was negative for lytic lesion. The renal ultrasound showed normal sized kidney. The whole body CT scan showed non-specific lytic foci in the skull. So basically, because she had 20 to 25% on the bone marrow, and she did not have any proven bony or extramedullary plasmacytoma, and she did not have at least proven involvement of the kidney, so she did not really fill the CRAB criteria, she was categorized by the hematologist in the category of smoldering myeloma. And, right now among the hematologist community, and obviously that might change in the future, if you have monoclonal gammopathy of unknown significance, and that usually comes with a small clone, so she had 2.9 gram per deciliter as a reminder, less than 10% on the bone marrow biopsy, no CRAB, you're just considered as having a monoclonal gammopathy of unknown significance, and you just monitor those people. If you have a bit more of an aggressive disease, which comes with more plasma cells on the bone marrow biopsy, but still no CRABs, you're considered as smoldering myeloma. And again, you just undergo surveillance, but probably more aggressively than for a simple MGUS. And you only treat those patients if you have more than 10% plasma cell and evidence of impact on health. Or if you have more than 60% plasma cells on the bone marrow biopsy, or if you have a very high free light chain burden, or if you have more than one focal lesions on MRI. So this is if you look at things from the lens of a hematologist. But what if this patient had actually kidney involvement? Then it would change the whole thing. Just to tell you quickly about lymphocytic and lymphoplasmacytic disorders. So here there is no mention at all about kidney dysfunction. And this is another major gap between the hematologist and the nephrologist. And they usually treat those people only if they have marked lymphocytosis, anemia, thrombocythemia, or lymphadenopathy, splenomegaly. So basically, if they just have hematological manifestations. And this is where the IKMG, or the International Kidney and Monoclonal Gammopathy Research Group, sought to fill that gap and said, well, you know, there is a category of patients which have actually kidney dysfunction as a result of this monoclonal gammopathy. And those patients need to be treated if we want to avoid progression of their kidney disease. And hence the definition of MGRS, it's any B cell or plasma cell clonal disorder that does not meet current hematological criteria for immediate treatment. So our patients having smoldering myeloma, if we can prove that she has kidney dysfunction, then she would qualify for treatment and she would be called an MGRS patient, but produces a nephrotoxic monoclonal immunoglobulin that directly or indirectly results in kidney disease or injury. An alternate definition would be a monoclonal gammopathy without overt associated lympho and or plasma cell proliferations with associated renal symptoms related to the monoclonal immunoglobulin or to the B cell clone by any mechanism other than tumor burden. A few words about the pathogenicity. So this is where we think in the case of MGRS, more than in the case of an overt hematological malignancy, it's about nephrotoxicity rather than tumor burden. And so it can be, the mechanism can be direct, where you have deposition of the monoclonal chain or immunoglobulin in the kidney, causing in most of the cases glomerular injury, but also in a select number of cases tubulointerstitial injury mainly. Or it could be indirect, as is the case for C3G associated with monoclonal immunoglobulin or TMA associated with that. Now, how common is MGRS? And it's important to answer this question because obviously, especially in low resource settings, you would want to know whether it's worth biopsying your patient, right? Whether it's worth fishing for a kidney disease there. And the case of this patient is probably something that you encounter quite often. And you really don't know what is the right course to do. So basically, we think that MGRS-related disease, and this comes from large centers, tertiary referral centers, and because they are retrospective studies, there's probably a selection bias, but they're present in approximately 40% of patients with monoclonal gammopathy who undergo a kidney biopsy. In her case, a 24-hour urine collection was done and showed around 2 grams of protein because, you know, I really wanted to make a decision here about the biopsy. And so I wanted a more accurate quantification of her proteinuria. And because she was a nurse by background, she did it quite well for me. And so basically, she ended up having almost 2 grams of proteinuria. So what should be done now? So this is where, going back to where this 40% came from. So in a study done at Mayo Clinic, which took all the patients diagnosed with monoclonal gammopathy between 2013 and 2018, and who underwent a kidney biopsy. So the most common pathology was AL amyloidosis. 40% had MGRS, 60% didn't have MGRS. The predictors of finding MGRS on the kidney biopsy was a proteinuria of more than 1.5 grams per day, hematuria in the urine, and an abnormal free light chain ratio. And in the case of our patients, I remind you that she did have an abnormal free light chain ratio, and she did have a proteinuria of more than 1.5 grams per day. There is another study coming from China, which showed basically almost the same thing. and said that you needed but basically also, so what's interesting about the study from China is that it was published 2 years after the study from Mayo Clinic. And because I had access to the study from Mayo Clinic because it had been published, they designed their study the exact same way. And they confirmed in their population, which was much larger than the one from Mayo Clinic, because they went through a much larger length of time, that yes, amyloidosis is the most frequent, but the second more frequent in their series was MIDD, while the second more frequent at Mayo Clinic was PGN-MID. Now, also as an insider, I have to tell you that the people from Mayo Clinic say, the pathologists from Mayo Clinic who actually described PGN-MID told me that a lot of pathologists outside of Mayo Clinic call PGN-MID MIDD. Does it make a difference in terms of a terminology? Probably it does, because typically people are more inclined to know how to treat MIDD, and you are more likely to find a clone in MIDD than in PGN-MID, which lately we were discovering that a large parts of the PGN-MID lesions in the kidney are not due to monoclonal gammopathy, but are actually due to a polyclonal gammopathy, and hence the mechanism is probably an autoimmune disease rather than a hematologic disorder. The third interesting part in the China series is that the third most common was thrombotic microangiopathy, something that was not present in Mayo. So the Chinese said yes, an abnormal free light chain ratio predicted that, the age predicted that, but proteinuria more than 1.5 gram per day predicted that, but not hematuria. And for them, the reason behind it was that in China, there is a lot of IgA nephropathy, and hence hematuria cannot discriminate those patients. Now, how do we diagnose MGRS? The circumstances when the MGRS is suspected, if you have the renal symptoms in a patient with known monoclonal gammopathy, so again, the case of our patients, or a kidney biopsy shows a monoclonal immunoglobulin-related renal lesion in a patient without known monoclonal gammopathy. So if you have renal symptoms in a patient with known monoclonal gammopathy, then you need to do a kidney biopsy. If you have a kidney biopsy that shows a monoclonal immunoglobulin-related renal lesion, then you have to fish for the monoclonal gammopathy and try to find it. So in general, the indications are otherwise unexplained kidney disease. If you have other cause or risk factor for CKD beside, the classical ones, diabetes, hypertension, but you have an atypical presentation or clinical course with an unexplained increase in proteinuria or decrease in GFR. You have suggestive extrarenal manifestations, and we'll talk about this in a second. You're young, and you have hemorrhagic complications. To have the perfect pathological workup, and I know it's not always easy to have it in many settings, and even in high-income countries, it's not always easy to have the whole panel done. But ideally, so light microscopy with congruent staining to exclude amyloidosis, immunofluorescence on frozen tissue to look for monotypic immunoglobulin deposits. And electron microscopy is really helpful to look at the distribution and ultrastructural pattern of deposits inclusions. In reference center, people do paraffin immunofluorescence. They also do immunoelectron microscopy. And what's become really more and more done is laser microdissection and mass spectrometry, something a technique that was developed at Mayo Clinic and that allowed to identify a lot of new entities. So obviously we ended up doing a kidney biopsy in this patient, and it did not show monoclonal gammopathy. It actually showed a classical diabetic kidney disease. So why do I give you this negative case? Because you could have all the perfect ingredients to have an MGRS, and it could not be there. To tell you about the clinical course, so the patient has been managed with what we think is now the standard of care for proteinuria in patients with CKD and diabetic kidney disease, but also in patients who do not have diabetic kidney disease, with lisinopril and an SGLT2 inhibitor. She's been followed very closely by hematology and by myself every 3 months. And up to this day, So their creatinine level has been getting worse, but that goes with the normal evolution of proteinuric diabetic kidney disease. The ratio, interestingly, went up to 11.71 in March 2024, and that coincided with a pneumonia that she had. And we know now that you can have transient micro peaks in the setting of infection, and they can regress spontaneously. So this is probably what happened. But essentially, her ratio has been unchanged. Let's go to clinical case 2. So we have a 49-year-old female who presented in October 2019 to her primary care physician with a chief complaint of chronic fatigue and migraine headaches. Routine labs were done and revealed the creatinine level at 1.24. Prior levels dated back to 2014 and were 0.9. And obviously, why would this patient have had more creatinine levels measured? She had no reason. She was thin, she was healthy, and she had no hypertension, no high blood pressure, and no diabetes. So she had a urine albumin creatinine ratio that was done and was found to be very low. But interestingly, the urine protein creatinine ratio was around 0.5 grams. And that triggered a whole serological workup for an early start of a glomerular disease. And what was striking is a very high kappa to lambda free light chain ratio at 22.6. Because the workup was done at Mayo Clinic, so patients at our institution often go back and forth between the two institutions, she had a new sophisticated technique called MALDI-TOF, which is more sensitive by far than SPEP with immunofixation. And you can detect very small clones. The result was cannot rule out a small monoclonal kappa on isotyping. But obviously, what really is interesting in this case is that this patient had a monoclonal gammopathy due to a fragment, not an entire immunoglobulin, and it was a kappa monoclonal gammopathy. She had an additional workup. So again, remember, she's at Mayo Clinic, so she gets a $1 million workup. She had a whole body CT, which showed no evidence of lytic lesion or plasmacytoma, and she had a bone marrow biopsy, which showed 8% kappa-restricted plasma cells. So she does have a small clone on her bone marrow. So here you have a healthy patient who has no reason, who's less than 50 years of age, who has no reason, who's a female, so it's usually more common in men, who has no reason to have a monoclonal gammopathy and yet has one, and it's free light chain only. So obviously the next step would be to do a kidney biopsy. And the biopsy showed crystalline structures within the tubular epithelial cell cytoplasm. And the final diagnosis was light chain proximal tubulopathy. And it makes complete sense with her current presentation. So this is where I'm going to say a few words about MGRS classification. So far, MGRS is classified more or less around the site of deposition of the monoclonal immunoglobulin. So as I showed you previously, most of them are pure glomerular disease. Some of them you can get the clone deposited in all the compartments. And in rare cases, such as light chain proximal tubulopathy, it's a pure tubular interstitial disease. And hence, the low level of proteinuria, the relatively low level of proteinuria that our patient had. It's also classified according to the histological and ultrastructural findings, and that's the main classification right now, and around the clinical syndrome. And in general, we differentiate between organized deposits and non-organized deposits. Organized deposits would be when you have fibrils or tubules. And if you have no deposits at all, and that's the case of C3 and TMA. So this is the IKNG classification that dates back to 2019, but this classification is going to change very soon. For instance, fibrillary GN already, all the experts tell you shouldn't be considered at all as part of the monoclonal gammopathies, and that's because only a tiny percentage of fibrillary GN have indeed monoclonal gammopathy. I also touched base about PGN-MID. So this is another big controversy and whether it should really be part of MGRS or not. And there is some thinking about now, so because those entities remember those, so those entities were described by pathologists. And as pathologists described them, they said, oh, if you find on a kidney biopsy features of PGNMID, you should look for a clone, and this is monoclonal gammopathy of renal significance. But as our understanding of those pathologies evolved, we realized that you can see this description on kidney biopsy, and then it doesn't necessarily represent a monoclonal gammopathy. So very likely the next classification will have what is for sure a monoclonal gammopathy, what is a monoclonal gammopathy in less than 50% of the cases, and what is a monoclonal gammopathy in less than 5% of the cases. And as an example, so the same group from Mayo Clinic realized, and this is where you need to know the difference between monotypic and monoclonal. So monotypic is when you have, let's say, I'm giving a random example, IgG3 kappa deposition. So this is a type of IgG, but and unique type that's deposited on the kidney biopsy. But monotypy is not synonymous of monoclonal. So, and in the case of fibrillary, for instance, despite the fact that they have monotypic deposits, only 0.7% were actually found to have a clone, especially if they're positive for DNAGB9. In terms of clinical syndrome, so amyloidosis, as you know, is a glomerular disease, so usually manifests as with heavy proteinuria and nephrotic syndrome. The pathologic findings are organized deposits with randomly oriented fibrils, 7 to 14. Amyloidosis, by essence, is a systemic disease, so you will have extrarenal manifestations. In other types of monoclonal gammopathy, this is much rarer. And for instance, in monoclonal immunotactoid, the extrarenal manifestations are exceedingly rare. In the case of type 1, what's typical, cryoglobulinic GN, what's typical beside the nephrotic syndrome and hematuria is a low C4 and a low C3. You will get extrarenal manifestations that are related to the cryoglobulin with purpuric rash, skin ulcers, peripheral neuropathy, and arthralgia. In the case of LCPT, there is a risk of stress fracture in up to 40%. And typically, you will have less proteinuria because it's a tubulointerstitial disease. In the case of PGNMID, for instance, you'll have heavy proteinuria nephrotic syndrome. You'll have, in most cases, it's monotypic immunoglobulin in the mesenchyme and GBM, but we now know you can also have PGNMID with a light chain, and we know now that the vast majority of PGNMID with a light chain are monoclonal, while the vast majority of PGNMID with monotypic immunoglobulin are not clonal, basically. In the case of monoclonal immunoglobulin with in MIDD, because it can deposit virtually everywhere in the kidney, you can have or not nephrotic syndrome. And it's also a systemic disease where you can have hepatic and cardiac manifestations. And here we get to the clone detection rate for MGRS. And it has to do, I think at this point you realize that it has to do with the sensitivity of the technique, but it has also to do with the fact that if you have a certain type of lesion on a kidney biopsy, it's not necessarily monoclonal again. So, and while in MIDD, you virtually always find a clone, especially if you do the serum free light chain assay. In PGNMID, you only find it in less than a third of the case. In C3 glomerulopathy, obviously, because you don't have any deposits, you think about it as an MGRS if you find a clone in the blood. So it makes sense that you get that sensitivity. Same thing for TMA. In the case of amyloidosis, I also showed you that, you know, if you combine SBEP with the serum free light chain, you basically only miss less than 5% of the cases. For monoclonal immunotactoid is roughly 50% of the cases where you'll find a clone. And for type 1 cryoglobulin, it's 76%. While for light chain proximal tubulopathy, it's a light chain disease. And it's for sure a monoclonal gammopathy. You'll always find a clone. I hope I think I'm doing good in terms of time, reasonably. So I just wanted to tell you that there are a few more techniques that are a bit more sensitive than the one I spoke about. For instance, immunoblot analysis. really allows you to know whether you're dealing with a clone or not, because in the case of immunoblot, you have antibodies that are specific for epitopes expressed by small sets of the variable regions. And this is where the clone comes from, while in general, the commercially available antibodies are directed towards the constant chain, which doesn't change. So hence, again, the distinction between isotypic and monotypic. And other sensitive technique, and this is the one used at Mayo Clinic, which is a mass spectrometry assays, which has a very high sensitive for the detection and isotyping of monoclonal immunoglobulin and can detect very low levels. The other important part, it can detect false positive on immunofixation, and it can distinguish between therapeutic antibodies from endogenous and proteins. And so the team from Mayo Clinic still had samples that were used by Robert Kyle in the first study that was made. Remember the study that I showed you on the first slide, and that is usually cited by almost every paper that talks about this topic. So Robert Kyle, when he published what he published, because it was in the 90s, at that time, people only used to do SPEP with immunofixation, and this is where the 3% number came from. And then if you add to this a serum-free light chain, you get 4.4%. And if you add the new technique used at Mayo Clinic, you get 5.1%. So this is to tell you that in general, you need to also do more hematologic workup and so bone marrow is indicated to distinguish between plasma cell, lymphocytic clone. And if you can't find anything on the bone marrow, you need to do a CT scan, a PET scan to look for plasmacytoma, to look for low-grade B-cell lymphoma. And sometimes you need to do an lymph node biopsy. One last technique I want to tell you about, a very sensitive technique developed in France, and to my knowledge, only available in France so far. And it's about taking bone marrow aspirate, extracting the RNA, having it go through light chain sequencing, then analyzing the light chain repertoire. And so this team from France found that in 16 patients, of which 11 had a negative bone marrow for any clone, they were able to find through this technique a monoclonal immunoglobulin secreting clone that matched the renal deposits in all the patients. A few words about the principles of management of MGRS. So there are important differences between the treatment of MGRS and hematologic malignancies with kidney involvement. There is no hematologic indication for treatment, meaning that the hematologists don't think that this is life-threatening, and this is why they wouldn't treat it from a hematologic perspective. In certain cases, you could just do careful surveillance, and that would be obviously with patients with just stages 1 and 2 CKD without evidence of progression and a proteinuria of less than 1 gram. And this is where the case of our patient with light chain proximal tubulopathy comes. And you would want to wonder whether she would need to be treated or not. In fact, she was treated, and quite aggressively. So she received initially bortezomib, and then it had to be decreased due to a concern for toxicity. Then she was switched to daratumumab. Her ratio went down to 3, so was normalized. And then they stopped treatment, and she's been for 3 years without any treatment. Her ratio is slowly rising, but her kidney function is very stable. And while she keeps on getting told that she could be in a very dangerous situation, she's still very stable. So, and because this entity is very rare, honestly, no one knows if she needed to be treated or not. The treatment is likely not indicated in elderly patients and frail patients, because again, in this case, if you think that it's not going to progress very quickly from a renal standpoint, and because you're going to give them toxic chemotherapy, you probably could do more harm than good. However, if you're considering transplanting your patient, then you need to be aggressive, and you need to aim from hematologic standpoint to either a very good partial remission or complete remission. And this is where I show you the hematologic response criteria for multiple myeloma, which have been extrapolated to the MGRS, but haven't really been validated in MGRS patients, but everybody uses them. because this is what we have. So a stringent complete response is if you normalize the serum free light chain ratio and you don't have any more clonal plasma cells on a bone marrow biopsy. A complete response is if you eliminate the clone peripherally and you have less than 5% plasma cells on a bone marrow biopsy. A very good partial response if you have an SPAP and UPAP that become negative, but you can still have a monoclonal protein detected by immunofixation, or more than 90% reduction in serum monoclonal paraprotein. And a partial response if you have more than 50% reduction in the serum monoclonal protein. For AL amyloidosis, it's slightly different, but it's still very similar to the responses that we talk about in multiple myeloma. So in general, the IKMG says you would consider someone having a very good partial hematologic response with MGRS if there is a difference between the involved and uninvolved free light chain of less than 40, or more than 90% reduction of the involved free light chain. And a strong hematologic response is considered as reduction of the involved free light chain to less than 2 milligrams per deciliter. For the treatment of MGRS, it's also extrapolated from hematologic malignancy. So for the plasma, if you find a plasma cell clone, then you give the typical treatment for myeloma. If you find a B cell or lymphoplasmacytic clone, then you give the typical treatment for for CLL, which is mainly, is rituximab as a backbone for myeloma, bortezomib and daratumumab increasingly at the backbone. If you have an unknown clone, then I would say probably in 2024, you would just go for daratumumab. And there is a trial going on now at Mayo Clinic, treating all the patients with PGMID with daratumumab. Or you could go for bortezomib if you have IgG, or rituximab if you have IgM, and alternate. How about the renal response criteria? So this is again extrapolated from AL amyloidosis, and this is actually set by hematologists. So this is the interesting part. And it's quite empirical, quite honestly. And certainly we need more numbers, we need strong studies to validate this. But we think that there should be a 50% decrease of the 24-hour urine protein, and creatinine clearance must worsen by 25% over baseline. And some people, interestingly, use those criteria, which are the amyloidosis criteria, and some people, again, use the myeloma criteria, which also have been set by hematologists. And if you look at what's published in the literature, it's all over the place. That's all I wanted to tell you today. I think I did reasonably okay in terms of time. I hope I didn't go too much overboard.
Thank you, Dr. Karam. Yes, indeed, you didn't go overboard. And thank you for unpacking the complex topic on MGRS in such a short time. And I believe now our audience is really enlightened on matters MGRS. At this point, I'll just want to open the floor to any questions or reactions to the presentation that we had. Participants, feel free to just type your questions in the chat box or even raise your hand. Then I'll probably give you a moment and then you can ask your question directly. For our panelists, they should be able to unmute themselves and ask. I think, yes, Professor Bima, yes, you can unmute yourself and ask your question.
Dr. Karam, thank you very much for that very enlightening talk. There's just one problem. As a pediatrician, I must say, I've never seen monoclonal gammopathy published in the pediatric literature. So for my ignorance, have you come across this in children?
To my knowledge, no, but there has been a couple of cases published in pregnant women, so you can have it in young patients for sure.
No, I'm talking about kids. You know what I mean? Less than
in
13
kids, not to my knowledge. I have also to admit my ignorance about the pediatric field.
Yeah.
I'm not a pediatrician, and I don't usually deal with children.
No, but I haven't seen any. No, I must have missed it if it's there, but it's so rare. But I've never seen any publication on it, I must say. So, it was all new ground to me, I must say. But thank you very much. Okay.
Thank you.
Thank you, Professor Bima. Yes, Dr. Lloyd?
Yeah, I mean, in this part of the world, in Africa, I think it's a very challenging area in the sense, there is a lack of awareness and understanding actually. Diagnostic facilities are limited, and of course there is misdiagnosis because of that. And again, even if there is a diagnosis made, the cost of treatment is pretty high. Medications are quite often not available, has to be brought in from India. And of course, there's a lack of research. So these are a number of challenges that we have, in the region, East African region, maybe in the other regions of Africa as well. And I think this is a phenomenal talk, really phenomenal talk, and really in depth to see, okay, how much of work is now going on in the area, the MGRS area, and I think I think I'm sure, as you said, there's so many new diagnostic areas that have now come up, and I think it's a big eye opener for the region, and I think this will stimulate, the need to do more investigations wherever it is relevant. Biopsies that need to be done in patients with kidney disease and suspected monoclonal gammapathy, probably easier than doing a lot of tests that are expensive, and immunofixation along light chains and screening. I think that is to be learned and done. I think, Dr. Karam, it's a phenomenal talk. Extremely grateful, and outlining everything that is really needed to be known in this. So, and it will be great for the fellows across the board in East Africa to actually look at the talk, and I will put it up on YouTube as well. There's a lot of information that you put into this small time frame, and a very comprehensive session. Extremely grateful for having come and spent so much time in here. Thank you so much.
So before I answer an excellent question in the chat, I just want to make a point. So it's important also, so I gave this talk not just, to educate people about MGRS, but also for me to be pragmatic and down to earth. And because I practiced in different settings, I certainly remember more than one patient coming to me and was end-stage kidney disease because a diagnosis of myeloma or amyloidosis had been missed by their nephrologist. And we all know that, a multiple myeloma and AL amyloidosis should be treated. You might make an argument about light chain proximal tubulopathy. Even people from Mayo Clinic will tell you, we're not sure how aggressive we have to be. And so if you miss a case of light chain proximal tubulopathy, it's not the end of the world. Your patient will survive. Their kidneys will probably be doing well for the rest, for many, many years. And it's fine. It's totally fine. If you don't have the resources, the right resources to diagnose and the right resources to treat, something that might be a luxury. But you don't want to miss a case of multiple myeloma. You don't want to miss a case of AL amyloidosis because those are so easily treatable, even with all the drugs, and kidney failure can be prevented. And this is where, again, if you see proteinuria, we're not sure where this is coming from. The presentation is atypical. Please do an SPAP with immunofixation. Please do a free light chain assay. If you diagnose 1 or 2 cases a year, you really save the kidneys and the life of those patients. Then I'll answer the question in the chat. Question in case 1, I know 30–40% develop DKD, but how likely to have DKD with HbA1c, which appears to be controlled like in case 1? I think I kind of think it was something like amyloidosis or MIDD, a word on that, please. So excellent question. So, well, first, I want to make a point here. If you look at the hemoglobin of this patient, she was quite anemic. And when I saw her, the first thing I was like, she smells cancer. This lady smells cancer. And I was not completely wrong because she has 20–30% of her bone marrow already invaded by plasma cells. So HbA1c in her case was not very reliable. The other thing that I think, so the general teaching for diabetic kidney disease is that if you have uncontrolled diabetes, then you will develop diabetic kidney disease. Yes, you will develop what I call personally, most of the time, the self-inflicted diabetic kidney disease, where you, and those are typically the cases which not necessarily develop nephrotic syndrome. And then you have a set of patients who develop nephrotic syndrome, no matter what you do, and they progress to end-stage kidney disease. And those probably have a very strong genetic component to their disease. And so this is where I would say some cases are within control, some cases are not within control at all. And I'm not sure about
that. Thank you for that, Dr. Sabine. I think we have Dr. Robert, who just, I think he had raised his hand at some point. Dr. Robert, feel free to unmute.
Yeah, Robert was a phenomenal friend and a role model. I'm really happy.
Yes, thank you very much. Thank you very much, Sabine. I just want to appreciate you coming here and talking to us. And also perhaps you could say, I think if time allows, you should say a word or two about the young nephrologists and perhaps encourage some of the young nephrologists here to join there. But anyway, it was a phenomenal talk. I guess the greatest challenge here is diagnosis, and I'm happy that you are saying if we are able to pick one or two cases, then we should be happy with that. So I think Professor Lloyd said a bit of what I wanted to say about the diagnostic challenges. And even after, once the diagnosis is made, the treatment becomes very expensive. But at least in Uganda, we have the Uganda Cancer Institute, and they have been very helpful in helping and treating these guys. But definitely it's worth the try because you save these people's lives. So, but I just want to thank you very much for giving this very wonderful talk and the organizers all together. Thank you. Nice to see you.
So yeah, so I'm very happy to be surrounded by young nephrologists who are really working in very difficult environments and thriving in those difficult environments. Please, if you're not ISN members, do join the ISN. It's free for low-income country, or it's very competitive for low middle-income countries. You will get access to a wealth of resources. Right now, the Young Nephrologist Committee that I'm sharing is revising the ISN Foundation Fellowship course. And this is actually accessible to anybody who's an ISN member on the ISN Academy. And in the future, we want, so there are two types of fellowship material now present on the ISN Academy. There is something called the ISN Foundation Fellowship course, which the ISN requires people who are applying to be ISN fellows to complete. And there is the ISN Fellowship Hybrid course, which is a series of lectures that also people have to complete once they've been accepted as ISN fellows. The great news about this is that they are accessible for physicians who are not ISN fellows. And if you complete those courses, you know that you have what you need to be a nephrologist. And even in the US at my institution, we struggle to give enough didactics to our fellows. And sometimes people from low-income settings get more lectures than people from high-income settings, because someone like me who's solicited to give a lecture will always do it, but not necessarily does it in his own home institution. It's paradoxical, but it is the case. The other advantage of joining ISN for trainees, for which it's free, for physicians who are not in training anymore, but come from low income and low middle income countries, you can join the Young Nephrologist Network, which is a network that we created as a Young Nephrologist Committee to involve more and more young nephrologists in many endeavors at the ISN level. So for instance, to revise this ISN fellowship course, I recruited 5 people from the Young Nephrologist Network. Our committee has 2 members from Africa. One of them is, I don't know if he's still here, Yannick. Yannick is here. Yannick is a member of our committee. Yannick from the RDC of Congo. We just also recruited someone from Tanzania. You know, their enthusiasm, their engagement to make this committee thrive and achieve a lot of great things. And right now we're designing also a course about how to interpret the scientific evidence of the literature. So there's a lot coming up, and it would be great for you to join.
Yeah, it's just a suggestion. I think, there needs to be a targeted approach into Africa from the ISN Education Committee. Some sort of a structured, targeted program that can come, specifically targeting African. You have wonderful people like Robert. You have wonderful people like Yannick and Dr. Elliott. So I think it's really nice to have some sort of a structured program. You see, when you generalize ISN talks, which comes from Europe, it really doesn't apply to us. You see, so you need to actually, just a suggestion that we need to actually, tailor make topics, simplified, and attract the younger people that needs to come from here. And it's a very important thing, I think. And of course, I'm glad that Dr. Yannick is there, Dr. Robert is here today, and they are regular people with us actually, and really nice. Dr. And a number of people come on as well. So there are a number of interested people. So just a question of gathering them together, and ISN can actually focus, and develop a small program with the same team here. And then, speakers can be got, and we could do that. It's a lot of learning. And I see there is a lot of change, and people like you come, there's a big awareness itself, you see. It's a huge awareness, the talk. On the diagnostic facilities may not be available. At least you'll make an attempt to make those diagnoses, because this awareness comes in. Biopsies, yeah, I need to do the biopsies. Let me go for the needles, get the needles into town, and then do the biopsies. Find the people who can actually interpret. Where can I send the slides? So these are all important things. And this makes a change, in the consequent generations that come. And once it's established, then it's established. Yeah. This is just an open, suggestion I thought should be there. Around the education committee, I think should focus into Africa. It's very important. With structured, thing, and come talk to the local people. It should not just be talks from there, from the ISN, and there should be some, some input. Get the local African crowd, and then structure this and put it in here. This is just a suggestion. Thank you very much. Thanks a lot for coming in here. It's a phenomenal talk, and thank you very, very much. It'll be on YouTube. And I think people will really relish this. There's so much of information, very important information that you put out today. Thank you.
So to answer your question about the ISN and what we're doing with Africa. So as a Young Nephrologist Committee, we did reach out to the Young Nephrologist Committee of AFRAN. Again, Yannick is part of this, and Khalida was part of this, Elliot was part of this. And we really, want to join forces with them because Young AFRAN to build something with the ISN, and we want to build something with Young AFRAN. So this is certainly something that we're looking forward to. Regarding the comment, and I know you're waiting to speak, John Philip, but regarding your comment, I was talking about ISN membership. I was not talking about ISN fellowship. Probably you are alluding to ISN fellowship. Yeah, the membership is free.
So I have pushed a lot of people into the membership, and about 10 to 12 people now we have trained from East Africa using the ISN fellowship now, and working with us right now, in Rwanda, Tanzania, Kenya, and now there are more people now coming from Zambia as well. This year there are people applying from Zambia, including pathologists. So I think this is a very useful thing. The fellowship program is really very useful, and I think they've done a lot for the region actually. And thank you so much.
You're welcome. So yeah, the full fellowship might not be, available to everybody, but the fellowship course is available to any ISN member, and any person from a low-income country can become a member for free, and any trainee from any country can become a member for free.
Thank you for that response. I think Dr. John has his hands up. Dr. John Gumbi, you can unmute yourself.
Thank you so much. I hope you can hear me very well.
Mm-hmm.
Yes, you're audible.
Yeah, it was just to top up of what Professor Lloyd has already said. It's about the ISN, and maybe it's an advice to ISN, and maybe we can take this up. Recently, for example, myself, I have applied for. I know the membership is free, and I'm a member, and I did the foundation course for the fellowship. And then I got the support of government, the letter where I'm working, and my application was just refused. It was just because I am working in a private facility, despite the fact that, for example, I'm in Tanzania. What we offer, what I do, is still from the same citizens of Tanzania. So it's just, and it went up because I had to present my letters from the government and the ministry to support my application and everything, but it didn't work out. So it's like the only thing that ISN looked at is if you're working in the private, then they won't fund you, like they won't support you. But if you're working in the government, then they'll support you. I feel like that turns down the effort of ISN to help low-income countries and to improve kidney care for these countries, because there are some of us, we are not in the government, and maybe we are motivated and we were like want to do for the training, but the only constraint is a financial issue. So I don't know. It's just a suggestion that maybe ISN can look at it in a different direction. If someone maybe has support from the government, really, even though they work in the private facilities, maybe they can think of something about that to increase the support to it and to hit the aim, what is supposed to be done, really. That is it. So just a suggestion from me. Yeah.
Sure. Unfortunately, I'm not part of the fellowship committee and I don't have any leverage.
Yeah.
But you could certainly email them and let them know your thoughts. And they're usually very responsive. And the people in charge are phenomenal. I would certainly do this.
Yeah, it's fine. It's fine.
Yeah, I agree with Dr. Sabine. They are very helpful and very, very, supportive. So I think, John, if you we could contact, and then I'm sure you should be able to submit it again. I can definitely, we can work together, no problem.
Yeah, it's okay. Thanks. Thank you.
Thank you, Dr. Lloyd. Thank you, Dr. John, for that question. And I'm sure ISN is doing a lot of work in terms of also capacity building, especially physicians also in Africa and across the world. Of course, more can still be done, even with other organizations coming in. So the future is bright. So, and again, with talks like this, quite enlightening to us. And thank you again, Dr. Sabine, for coming in and taking us through this topic. Like I said, you really unpacked it in a simple way with really nice case-based insights that made it simpler for our audience. And on behalf of our panelists and Africa Healthcare Network, I just want to convey my thanks and I wish to have you again in future to discuss more interesting topics.
Thank you.
I just want to say thank you and good evening. Yes.
One last thing before everybody parts. And Yannick is still there, thank you. I just want to say that, yes, the ISN is trying their best. Yes, there is never enough to be done. There's always more stuff that to be done. But I can say that you guys are also inspiring and you are doing a lot in your own region to make things better. So for instance, after the scientific writing course, there was a webinar that took place, which told everybody else about the highlights of the scientific working course. And that was phenomenal and that was inspiring to us. And because of that, we're going to reach out. So the next scientific course is taking part in the Asia Pacific region. We're going to reach out to the Asia Pacific region for them to replicate what you did, guys, after the scientific writing course. So a little something can go a long way. And we're also
yes. So I'm going to list the young nephrologists wherever I can and send them to you. I'm going to connect them to you, all the young nephrologists. That is something I'm going to really work on. Everyone in East Africa, I will list out the young people who are passing out, who are in the training program, and who are passing out. I think it's very important to list, and then you get to know them. Some of them are very, like Philip John is a very, very, an outstanding guy for the future. I can tell you that he is very attentive. He's very knowledgeable. He takes every slide from every talk and he goes into the videos in detail. But unfortunately, that he's not got the ISN fellowship. I didn't realize that. So I thought he was already going into South Africa with Dr. Davids, Racine Davids. Yeah. So anyway, I'm sure he'll make it. So there are a number of people like that. Yeah. I will connect for sure. Thank you so much for coming on. Thank you very, very much.
I just want to wish everyone a good evening. Thank you, Dr. Lloyd. And just a couple of announcements. Posted the link to CPD points. So if you're a doctor in Tanzania or Kenya and you want to claim CPD points, kindly just go to the chat box and click on the link. For nurses in Kenya, there's also a message on how you are able to access CPD points. And like Dr. Lloyd mentioned, this session is going to be uploaded on YouTube so that we can catch it later and go through it at your own time as we continue learning. Thank you for making time and wish you a good evening.